I'm Laura Allen. I'm a pediatric orthopedic surgeon in, get this right, Saskatchewan. My goal was to address chronic pain in adolescent orthopedic patients. To better do that, thank you to my co-contributors. My aim was to create a pathway to identify and address mental health disorders and pain behaviors that are known to magnify MSK pain in adolescents. So I really wanted to change from my very closed orthopedic point of view and try to consider other factors that might be playing a role in my patient's pain experience. And this kind of stemmed from a review of, I saw 41 back pain referrals. Of course, they all get a history and physical and x-rays. About 3/4 underwent an MRI, so we did a really deep dive. Out of all those patients, 1/4 had an orthopedic diagnosis, and then 1 went on to surgery. So there wasn't a lot of orthopedic action, I would say, but there's still a lot of patients experiencing pain. So I thought that we should start with a validated screening tool, and we tried several. We did several small PDSA cycles. We started with a PHQA, which is short and easy, quick and easy, but it only addresses depression, and there's a suicide question. SDQ is honestly overboard. We went the other way. There's too many questions. It wasn't all important or relevant to us. And PCS, which is pain catastrophizing scale, was nice, but it didn't address any of the mental health symptoms. So my challenges were, 1, lack of a perfect screening tool. 2, difficulty recruiting a patient advisor. It's kind of a delicate situation, and it's in the pediatric age group. And then there's severely limited system resources to address and manage mental health needs in the province. So in a way, I think we did move away from, you can see the yellow arrow, the idea is to move away from this disgruntled discharge where the patient doesn't feel like they have the answers they're looking for. There's more follow-up, there's more second opinions, there are ER visits. And instead, I still do very general orthopedic consult evaluation imaging as needed, but I'm a lot more comfortable going down to that pathway there where we just have a frank discussion about mental health symptoms, pain catastrophizing symptoms or behaviors, and if we think it's appropriate, we'll engage the GP if they're available, seek out some community resources, online education, and sometimes some direct referrals. So it's small, but this is a copy of the handout we have so far. So in conclusion, mental health issues, pain perceptions, and behaviors are commonly encountered in the adolescent orthopedic population. I think a very simple pathway can help to meet the patient's goals of pain management, even when an orthopedic diagnosis is absent. In the end, at this point, I don't think I need to formally screen patients. It can be confusing and frustrating for the patients and families that they're seeing an orthopedic surgeon. We're talking kind of softer elements. It can negatively impact our interaction, and it's really important that we have a good one, and it's time-consuming. I think it's easier, more natural to discuss mental health symptoms, pain catastrophizing behaviors, and how those entities might relate to each specific patient depending on our specific interactions. Thank you.